So this is my last topic. This is the opposite end of the spectrum as far as being a burn surgeon. And living in Louisiana, I would say we're never going to see this, but there's a couple of instances where we will. When you start studying on this, I really don't have any particular knowledge or interest in this. However, when you start reading on it, there's a lot more written in this subject about kind of hypothermia insults where somebody, lays out on the side of a mountain or is drunk, whatever, up in northern climates or something like that. But there is a little bit of wound stuff, but the wound stuff from our standpoint is pretty easy, and I think we're probably more likely to see it in somebody that's homeless walking around in wet shoes, and it's not really going to be frostbite. It's going to be more of a trench foot thing, and I've got some pictures and a little bit of discussion, very little discussion on that. Or somebody, I've seen a few that work in like refrigeration, whatever, it's not Freon anymore, but whatever, where they get a leak and it sprays out on their fingers and that kind of stuff. So we'll kind of get started on this. But it seems to me this is pretty easy to kind of take care of, and it's certainly not an emergency as far as the wound. So frostbite is a disease of morbidity where you're worried about losing fingers or hands or feet or cosmetic parts of the face, and it's not really something that'll kill you. You might die of hypothermia, but not of the actual frostbite injury. And what it is a localized freezing injury. So it's common at kind of the tips of the nose, tips of the fingers, can go up more proximal fingers, hands, toes, feet, but exposed areas. And so what happens is with the freezing injury, there's immediate cell death. First, the extracellular ice crystals form, and then actually ice crystals within the cells, called cell lysis and death. And then there's eventual ischemia and necrosis. So really, you can kind of think of this as dry gangrene. Risk factors, obviously are cold climates. Exposure, somebody that goes out with inadequate clothing and then has some kind of insult where they can't get away from that. And conductive heat loss is a big deal where there's contact with metal. If you're laying out exposed in contact with metal or the ground just simply through your shoes, or wet and exposure to water. Exhaustion and dehydration is just a factor in that you can't get away from whatever environment that you're having trouble in. Peripheral vascular disease and diabetes are going to be bad for circulation. Smoking is vasoconstrictive, so that's going to be bad for peripheral flow too. Mental illness, that's just making bad decisions or going out and not having adequate clothing or gear. Alcohol abuse is another kind of in that same vein with behavioral changes or bad decision. And there's a vasodilation during alcohol consumption and therefore a heat loss. This is probably how we'll see it down here. This is the teenage thing. I haven't seen one yet, but a bunch of friends of mine have sent me this from Facebook and stuff. So the challenge is you make kind of a slurry of salt and water and put it on your skin and see how long you can tolerate the ice cubes on. Guess what happens? So, bad choices. So this goes this way, kind of snakes around, but it makes sense. Exposure to cold with ice crystals forming in the tissue. There's a profound vasoconstriction from the ice, but just from the cold too, where the body is trying to warm the core at the expense of the periphery. With that, you get sludging in the capillaries to the point blood flow stops. Treatment is obviously warming, thawing, and after that happens, there's a reperfusion injury with all the release of inflammatory mediators, the list. I didn't put all that. Nobody learns those anymore. And with that reperfusion injury, the endothelial cells actually dislodge and embolize distally, causing thrombosis and necrosis. So you have the original freezing cold insult that's followed by a reperfusion injury. So it takes some time before that kind of declares itself. Okay? Treatment is rewarming. There's stuff in reading about this about, it's these explorers and people out in just extreme climates where they have this and then they get to some little hut or whatever and they try to rewarm, but then they go out and get exposed again. That's probably the worst thing that could happen. You want to thaw one time. So get them to some kind of shelter or medical system where they can warm them. And the way that you warm these people is to immerse the tissue in warm water, about 100 degrees. You don't want to go hot because then you're going to put a burn on top of it. Another no-no is to rub the tissue because you're causing local trauma. And when they're sitting there in their water bath, you don't want their hands banging around on the sides because that induces further trauma. So just sit there and maybe just a little bit of gentle range of motion. This is very painful. They need narcotics. Ideally, a kind of a whirlpool where you can set an actual temperature and keep it at that steady temperature, so about 100 degrees. And you don't want to sit next to a stove or fire because then you can add a burn on top. Diagnosis for the most part is clinical. Adequate history and physical exam are usually pretty obvious. There is writing, and it's tough to find any pictures of getting bone scans so that you can identify the perfusion. I didn't know you used a bone scan for this, but I do have one picture I can show you. And angiography. The bone scan and the angiography are a little bit more extreme kind of workup, but those are people that you would be worried about amputation of multiple digits or a more proximal amputation, so it may be more important to try to reestablish flow. So in general, a couple of toes, sorry, it's your toes, you're probably going to lose them, but a hand or something, you might be more aggressive. Okay, so here's the one picture I could find of a bone scan. And so, thank you, Harvard. So you just see there's no flow kind of in the distal parts. And so the most aggressive treatment for this is TPA because of the thrombosis injury and distal embolization. So the people that are at high risk for amputation of multiple digits, probably more hands than toes, or more proximal amputations who present within 24 hours. If there's no contraindication, no bleeding risk, those people can be given intra-arterial TPA. Again, we're probably not going to see these patients down here. This is the old classification. By old, I mean last year in a score. And it kind of parallels kind of the burn injury. I guess that's why we get into it. So first degree is a little bit of hyperemia, maybe a little bit of edema. Second shows some blistering with clear blisters. Third would be more hemorrhagic blisters, meaning the injury is deeper into or through the dermis. And fourth is full thickness necrosis. Okay, so this is just that in words. There's kind of superficial versus deep, and blisters are an important part of kind of determining that, but not so much. I actually like this classification better, where they divide it into 4 grades, and it's more so that this helps you predict or kind of get an idea of where you're going to have to amputate, because that's the treatment of this. You wait it out and you amputate it. So grade 1 is just going to be some erythema, and these are all graded after rewarming. You can't tell anything when they present. Grade 2, you would see cyanosis, and that's from the thrombosis of the blood vessels. So cyanosis to the distal phalanx, cyanosis to the middle or proximal, and then cyanosis going across the carpal or tarsal bones. So this helps you predict your level of amputation. And so this is a picture I found of a presentation. And so this would be ice cold, insensate. It'll be hard. It's frozen. Okay? So it doesn't look, it looks okay. It doesn't look that bad, but I wish they had followed this one all the way through. But then these are just from up to date. I couldn't find a really good set of photographs to describe the injuries, but in this black and white picture, apparently that's erythema. So just a little bit of pink down here on the color. You don't see any blisters. So that's grade 1. Grade 2, you can kind of see this. There's a real discrete line right here, right at the distal phalanx, okay? So, if all this is dead and we're talking about doing amputations, you're going to have to come back here into viable tissue. So, even with just the distal parts, you're likely talking about, middle phalanx amputations. That's probably a pretty good picture in color. But very discrete line of demarcation of viable versus non-viable. Grade 4, this is bad, all the way up here. So that's a forearm amputation. Here's some color pictures. So the hemorrhagic blisters, that looks horrible. That's going to be a treat to take care of. But the other thing in reading about these, a burn surgeon is going to want to debride these blisters. But you don't want to really do that in this because at this point, that's kind of a sterile process. Think of it as dry gangrene, even though there's blisters. So the treatment recommendation is to just drain those blisters. Hopefully that blister skin will collapse down and kind of seal. As far as wound care, there's not much to do. All you want to do is wrap them dry, wrap each digit individually in dry gauze to protect them, and just kind of allow them to demarcate. You want to let them progress to dry gangrene to give you an idea of where you want to amputate, because you want to preserve as much tissue as possible. But these toes, kind of cyanotic, these are hemorrhagic blisters down under there. Just drain them with a needle and let that skin collapse down. This is an ominous sign, apparently, where it's cyanotic, kind of hemorrhagic, but it's completely dry. So that dermis is dead. It can't even make that fluid to form a blister. So this is pretty ominous here. And you can see all they did was just dunk some 4x4s in between each of the toes. You just want to keep that dry so you don't get a crack in the skin and a portal where some infection can get in there. Here's another back picture. This is like sit and wait, so it's going to be all the way back here. When you see it, it's right there. Here's another one. This picture is kind of puzzling. Why are they outside in rocks? They've got their fingers that they're about. But again, hemorrhagic blisters. Just drain them, let them collapse down, and sit tight. Here's some that have been observed. This is a little bit later. You can see actually some partial healing up here, some more superficial blisters in this. I mean, maybe lose this fingertip, sit tight on these, maybe it'll heal. This looks like somebody that works in refrigeration. It's just on the pads of the fingers, a little bit worse on this left hand. Cyanosis here to the middle phalanx. Okay, so here's the rule of thumb. Basically means sit tight. Frostbite in January, amputate in June. So what you want to do is wait 3 or 4 weeks. You know, and if they go ahead and do that for you, you don't have to do anything. Okay, so there's no rush. There's no rush. And this guy too, talking about frostbite, he's made a career out of this. He was injured climbing Mount McKinley, some kind of weather insult. Anyway, he got stuck. So he lost his nose. He's got an excellent prosthetic nose. And he's an inspirational speaker and stuff, so not all bad. This is probably what we would see here too. This is probably more concerning to me than the guy who makes bad decisions and goes out to take care of your pet. Apparently it's a big deal too with people that raise chickens. So think about that. This is probably something, well, not even this. We wouldn't see this. These are the lesser degrees and maybe actually something that might happen in our climate. Chilblains. I've seen it, chilblains, or pernio. I kind of like pernio. And this is exposure to a damp, cold environment that is not to the level of freezing. So this is repetitive injury. And so these purple lesions are quite painful or pruritic. Sometimes it can progress to kind of a blistering or ulcering lesion. And it's kind of a repeated injury, so there's scarring and fibrosis and maybe some atrophy. But there's really not that much to do. This is kind of a pain issue, and avoid that environment. This lecture's short today. This is probably something we would get called to see. This is now a disease of the homeless. It was a disease of World War II soldiers, where the clothing for soldiers has gotten a lot better, and the socks and stuff. One of our silver representatives actually brought us some socks they were trying to develop for the military that had some kind of silver something in them. But you could wear them for 6 weeks and never take them off. That's just gross. But anyway. So the boots are more waterproof, which is going to lock in sweat, but it locks out water that you might be walking through. But they actually used to have foot inspections to check people for this. But it's another disease of morbidity, not necessarily mortality, but kind of red ulcerative lesions on the feet, maybe dry, maybe some hemorrhagic bulla, but it can progress to necrosis. So, you know, homeless guy with wet, macerated feet, just kind of treat these with dry dressings and kind of see what happens. You know, a lot of soap and water and dry. Here's another one. You'll see it sometimes in athletes, sweaty feet, out running. Get it. This is kind of more of a chronic condition. This you want to treat with just dry. These little superficial blisters. This is more of a sweaty feet and friction abrasions within the shoes. These little superficial, and I mean, this is different than frostbite, right? You don't have the cyanosis, and it's not really of the distal tips. So you got these little superficial blisters. These you would probably treat with something simple, Neosporin, Silvadene, or something like that. So that's immersion foot, where it's cold and wet, but not free. And with it is a little bit of trauma. That's all we have today on frostbite. Any questions? That's it.
Oral boards will get hypothermia as the full case scenario. It goes to the whole 7-minute thing, hypothermia. Interesting.
That's all I have. If you pick